Thanks all for coming. I'm very honored to be here, and we have a great schedule today, and already this morning we've learned a lot about the program here, which we're very impressed by. The sequence that Raj and I are going to do today, I'm going to just give a general overview of human factors engineering and how we're applying it in healthcare as a general overview. And I know many of you understand human factors, and I was asked to talk a little bit for those that aren't familiar with human factors, so I'll have just a couple minutes on what human factors engineering is and how it applies to safety specifically, which is much of our interest. And then Raj is going to, I'll segue into Raj, where he'll talk about specifically how our team has been applying human factors engineering principles in the health IT environment, and he'll give some examples of our research projects. So with my part, I really want to focus on safety, and my goal is to have you view safety from the lens of human factors and safety science. And what I'll do in doing that, I'm going to relate a couple examples from our center. So I'm also going to give you a very brief 30-second overview on the context that Raj and I live in professionally and what our center does. But I want to just get out of the way very quickly for those new to human factors engineering. What our chief innovation officer likes to say, the best way to define something is to say what it is not. And human factors engineering is not designing people. In fact, it's quite the opposite. It's about designing the systems and devices that people use based on good scientific performance data that describes what those people are. Our center takes those different methods from the field of human factors engineering, which, by the way, comes from two domains. You can get an advanced degree in human factors from either the cognitive psychology world or the industrial systems engineering world. And we have both human factors engineers as practitioners really use the same body of literature and knowledge no matter which academic track they came through. And our goal in our center is to improve healthcare quality, efficiency, reliability by applying these principles. And our center is in the MedStar health system, which is a 10-hospital, $5.2 billion annual revenue nonprofit healthcare delivery system in the DC and Baltimore area. Georgetown University is one of our hospitals, and our academic affiliation is all with Georgetown University. And our center really does applied work and research work. Our research work is focused on being applied. We like to say that we try not to do any research that's just going to get dusty on journal shelves in libraries. We want it to be useful and applied, and that's one of our principles when we triage what we're going to do. That's second only to what is fundable. So, as I'm sure you understand. So we do a major research and development phase. We also have a large part of our group that does internal safety consulting within and outside of MedStar Health, and we have a usability services group that does usability work for mostly device vendors, but also some health IT vendors. And then we do a lot of healthcare safety engineering as well, and we do some education. We're about 24 people. It's embedded clinicians embedded in the healthcare system with PhDs and safety scientists from the human factors discipline. And we try to, although we're a very traditional academic center that does the traditional cycle of grants, work, and papers, and trying to have an impact that way, we also, as Dean said in the introductions, do a lot of government policy and influence work, service within the MedStar health system, and work with other organizations to try to change the safety profile nationally through these methods. So I wanted to give you that as background, just a little bit about how we view human factors and the context that Raj and I live in. And now what I want to do is really focus on what human factors engineering is so that Raj can go into how we apply that in the health IT domain. So in terms of safety, this is Lucian Leap's slide. Maybe many of you have seen it. But it reminds us that from a risk analysis fatality rate, participating in healthcare is just about the most dangerous thing you can do. It's about the same as bungee jumping. And it's so much less safe than commercial aviation and nuclear power. People think of aviation as an unsafe activity. And my clinical domain is emergency medicine, and when I'm in ED, which I do once a week in Washington Hospital Center, I'll often have patients that are upset or angry or disappointed when I tell them what their diagnosis is, but that they don't need to be admitted to the hospital. And they don't realize how risky it is to be admitted to any hospital. I don't mean our hospital in particular, of course. And so why is it, though, that we're so unsafe? If you think about the year 2000, I know that we all get nauseated when we hear the to err is human reference, the IOM in 1999. But if you think about it, that changed everything. It changed the focus of safety in healthcare. We had, starting then, before then, we might have had a director of something in charge of safety. Now we have senior leaders in every C-suite responsible for safety and quality. We have regulation, we have payment methods around it, we have public scrutiny. The government passed legislation like they do with most IOM reports saying that there would be 50% less error in 5 years. That didn't happen. There's been a whole focus on it, yet in the many years, 16 going on 17 years since this report came out, there has been no change. If you look at this, there have been pockets of change. Many of you right now are probably thinking, well, what about ventilator-associated pneumonia or this or that? But if you look at our overall rate of causing harm to patients in the United States, it has not changed in 16 years, despite this huge change in focus. And safety engineers on the outside look into healthcare and they say, well, that's obvious because you all are still focused on individual performance. If you think of the cartoon of this, we put all of our safety focus on the backs of our frontline providers, saying if you could just be safer next time, have a mindful moment, be careful and do this better next time, and we'll retrain you and put you in, back in, and you better be safer. And we continue to think that's our way to get safer. And most of our solutions have not been consistent with safety science. If you look at after an adverse event, there's a big, deep RCA that's done. Usually they don't come up with the right contributing factors, but in the cases where they do, they often come up with solutions that aren't consistent from a safety science standpoint with actual sustainability or effectiveness in terms of correcting the problem. And I'm going to give you an example in a minute to bring that to life more. So the overall problem is we have this idea that we're going to make it safer by eliminating human error. And as you see, this I'm proposing to you, what safety engineers in other fields have known for many years, that that's not the solution because we learned it as 2, 3, or 4-year-olds. The main, one of the first principles we learned from our parents is human error is part of life. Everybody makes mistakes, right? And I am not saying that we should have subpar, lax doctors and nurses and respiratory therapists and pharmacists that just make a lot of mistakes. What I'm saying is when you take really well-trained people that are trained to the standards that we train our healthcare professionals to in the United States, very high level of competency, that come to work well-rested to do the best job they can, the system sets them up for error, and there will be human error on a predictable and repeated basis. So by us believing that we can get safer as a system by eliminating human error, it's a futile goal, and it misdirects our resources, and it actually makes it harder for us to do this well because it creates this culture of secrecy and blame. That means we can't learn about where the hazards are, which would allow us to then fix the system so that errors can occur, but their impact is mitigated. And that's really what the way human factors engineering can influence safety, both in the health IT world and outside of the health IT world. You know that aviation has done this well. They took on this systems approach in the early 70s. And if you look at the accident records, aviation was truly a dangerous thing to do before this transition, and now it's one of the safest things you can do. The large carriers, the major air carriers, are safer and have better safety records than the regionals. And if you look at just the major air carriers in the United States, it's been over a decade since they have had a single fatality. Not just an airplane crash, but a single fatality of a major airliner. And not talking about the regionals. I understand there was the regional crash in Buffalo, so one in the last decade. But no fatalities. And that even means not even a baggage handler run over on the tarmac, which used to happen not infrequently. So they have really been able to do that, and that's despite numbers of 109 million airline passengers, 30,000 flights per day. Now, half of you in this room right now are sick and tired of hearing aviation analogies, and you're considering whether you should leave because you think I'm going to continue this. So I'll say 2 things. One is I'm not going to continue it, but the second is when I talk to my colleagues in healthcare, and they say, we're different, the patient's more complex and all that. I'm not talking about taking very specific solutions from aviation and mapping them to healthcare. I'm talking about the general principles of safety engineering that have made the nuclear industry, military command and control, aviation, and other complex high-risk industries ultra safe. We in healthcare don't really want to adapt that really readily. And probably the easiest examples to explain that come in the health IT world, right? When I first started talking about this, I asked a colleague of mine who was just retiring after a lifetime of aviation human factors experience. He was one of the most well-known aviation human factors professors in the world. And I called him up and I said, I'm preparing my first talk comparing aviation and medicine. I want to know, what do you think are the similarities and differences? And he said, well, the biggest similarity is that when we started trying to apply these principles in aviation in the early 1970s, they kept saying, we're different. So I just want to leave you with that and say it actually does work. And so I'm not going to talk anymore about aviation, but I want you to think about the principles I'm going to talk about and try to map that to how it's worked in aviation. So human factors engineering uses disciplines that study and have good science behind behavior and cognition, the abilities and limitations of human performance, the physical traits. Another word for human factors engineering is ergonomics. That's what they call it in Europe. And you all know an ergonomically designed chair, which uses data about the physical characteristics of the human body and how the human body best sits. And then they build that chair to meet the 95th percentile, essentially. And they use that to design all the things listed here, and they do it to make it more productive, more safe, more comfortable, and more effective for human use. Now, the interesting thing when you think about healthcare, often we're very parochial about things, and when we want to do something well, we try to find a doctor or nurse and have them read a book, and then they become our expert in it. When we have this world of disciplines around us that with people with PhDs in this area, and we should infuse that more. And this is a true specialty that if you look back and you look at the origins of health IT, if we had first started with studying the way people do their work and then trying to build a cognitive support tool that helps them do their work better and more efficiently, including the way data comes in and out of the system, we would not have this era of, quote, resistance to health IT and people that are perceived as not as resisting change. So I'm going to use to demonstrate the philosophy that I've just portrayed to you, I want to use a medical device example, and then Raj is going to give several health IT examples. If you think about my domain is emergency medicine, I used to be a paramedic, I love defibrillators, it was one of the first things I studied. If you think about defibrillation, especially in the adult population, in peds it's usually asystole from hypoxia, right? But in the adult population, people usually drop dead in ventricular fibrillation, which is that heart rhythm that if you shock it right away, you can save their life. They'll come back to life. The media calls it a survival rate. I call it a miracle rate, resuscitation. But every minute that goes by is a 10% less chance of resuscitating that patient. So I'll give you a scenario. Patient goes into cardiac arrest. The nurse is there, witnesses the cardiac arrest. The person's in ventricular fibrillation, so you can shock them back to life. The nurse does everything right, charges up the defibrillator, says clear, but then instead of pressing the shock button right here, the nurse presses that on button. What happens on a defibrillator if you press the on button instead of the shock button when you're ready to shock? You have a dead patient in front of you. You can save their life. Every second counts, and you press this button by accident. Yeah, it just turns off. And then what happens if you have a patient in cardiac arrest in front of you and you inadvertently power down the defibrillator? Well, it takes 2 to 3 minutes, right here, depending on the manufacturer, to restart and then get recharged up to give the shock. So you've lost 20 to 30% chance of resuscitation. So compare that to a very common consumer electronic device. What happens if I could reach that slide projector right now, or any slide projector I've ever used in the United States, and I inadvertently press the power button? What happens? Yeah, it gives you this thing, right? It's some variation depending on the vendor. Are you sure you want to shut me down? Why does it do that? Because the consumer electronic company has anticipated normal expected human error of their users, right? And they don't try to train them. They don't try to have them have a mindful moment. They don't try to have a policy that says don't power down the slide projector when you don't mean to. You know, they don't do any of those normal healthcare interventions. And there's chuckling out there, but that is our approach to human error in healthcare. And then we wonder why we're not getting safer. So instead, they've designed this device to not prevent human error, but mitigate it, so that you don't have an adverse effect or an adverse impact from the inadvertent powering down of a slide projector. Yet, there's no way you can really hurt or injure or kill a patient by inadvertently powering down a slide projector. Maybe someone could come up with a scenario if you're in some country where it's very dangerous to make a mistake. I don't know. But you really can't have a human being be hurt by this. So this is because this is the culture in healthcare, is that everything's on the frontline provider. And the error that occurs in this defibrillator example is what James Reason, who's kind of the father of error science, would say is a skills-based error. Now that doesn't mean technical skills like IV intubation and all that. It means skills-based means something you do every day, day in and day out, and you don't think about the task, so you're in automation mode. The same thing you do when you're opening a door, and I'll give you an example of that. But these cause slips and lapses. The skills-based error mode is slips and lapses, and slips and lapses cannot be reduced. The error rate cannot be reduced with these things: policies, in-services, training, vigilance, and all that kind of thing. This maps really easily to health IT error and safety, right? Because so often, instead of optimizing design and trying to reduce the impact of error or reduce facilitated error through the impact, the design of health IT, we think that better training. In fact, one vendor, I referenced this earlier today, but one large vendor in the US has a really good data collection system to look, so that you can go into their system and look at the data of your users, and they sell it to their healthcare organizations as a way to look for the users that need better training, not to look for the areas in the health IT design that probably need design change, because errors that occur are going to be repeated if they're skills-based errors. So the Errors Human title told us this, right? We shouldn't be trying to get safer by changing the human error rate. We should be trying to get safer by anticipating human error and designing so we don't facilitate it, and then designing so that we mitigate it. A great example is a skills-based error comes from Don Norman's book, The Design of Everyday Things, where he uses the example of a door handle, which to a human factors engineer, everything has a display and a control. The control of the door handle is obvious, but the display that's most powerful in your mind as you approach that door, because you're in skills-based mode, you're not thinking about opening the door, but your mind is communicating with this door handle, which is telling you what? It's telling you to pull, right? But the big sign in front of your face is telling you to push. Why is this sign not effective at all? It's because you're in skills-based mode. You're not reading signs to tell you how to operate a door. Your mind is communicating with the door, but it's communicating with the interface. So instead of training users about how to use the door, or doing an RCA after they used it wrong and saying, well, they should have read the sign and they've been trained in how to use doors and they had their competency, oh, and we had a policy that if it says push, you should push, and not to boot, they came in the door so they should have known how to go out the door. Based on their experience, we should suspend them and retrain them. Instead, could do a simple design. The elegance of this design is twofold from a human factors design standpoint, right? Number one, there's a forcing function involved, because it's actually almost impossible to pull on that door. You cannot make the error that we don't want them to make. Secondly, the door communicates appropriately with the user. Now this is kind of an obvious thing, right? But in the design of more complex system components, including health IT, sometimes this stuff isn't obvious, and that's why we need a special discipline of people that come with the knowledge of some of these population stereotypes or affordances, as we call, or that are really good at powerful ethnographic research to figure out the questions that haven't already been answered. So you can see how this skills-based error maps to common errors that we make, like the high-dose heparin and the low-dose heparin that are in the same exact bottle. Can you imagine designing a system where one medicine is given day in and day out by nurses 10 or 20 times in their shift as a direct injection, and then designing that to be in the same exact bottle of something that if you give it by direct injection, you kill the patient. I mean, this is our system today in healthcare. Can you imagine that? If you tell people outside of the healthcare environment, if you told a safety engineer in another complex high-risk industry that we did this, they'd be floored. So the cause of our safety problem is not bad people. It is the complex, messy system and the design. And so that will kind of set Raj up for when he talks about how we apply health IT in healthcare. What we are most passionate about is how it affects safety. Now, it definitely affects other things like efficiency, satisfaction, and quality, but safety is the most important thing. And I'll leave you with this mantra: just try harder is not a strategy. The safety attitudes, this is a Lucian Leap saying the single greatest impediment to error prevention in the medical industry is that we punish people for making mistakes. And this old data that shows there's 600 hazards and near misses for every event that injures a patient. So if we can really understand, and this is where informatics can really help us in health IT, is understanding where the hazards are, and then not trying to train people not to do it wrong anymore, but try to change the design based on that. So Einstein said this, you've all heard this quote, but I think it really applies to how we try to do safety and design. And Jim Reason said fallibility is the part of the human condition, and we cannot change the human condition, but we can change the conditions under which people work. And this is where health IT is exceptionally powerful. Because if we try to change those conditions in healthcare, a lot of our method and mode of change is through health IT. So with that, I'm going to transition to Dr. Ratwani, who's going to now take what I've said and try to bring this more to the ground in the health IT sense.
So I try to never follow Terry because he's such a great speaker, but somehow I always get stuck in that position. And I've probably heard him speak, I don't know, 100 times, and every time he speaks I want to run out of the room, pull signs off the wall, start redesigning, because I think it's so compelling and so charged. So I'm going to transition a little bit and start talking about our health IT work. And we do a lot of research at our center. A big focus for us is certainly health information technology, and I'm really going to focus on the usability and safety components of that. Now, before I do that, quick survey, how many folks here love their EHR? I see one, maybe half a hand up. That's it? How many people engaged in Cyber Monday and ordered something online? And how was that experience? Pretty good? Any sites crash? No? Any frustration after you order? I can order things in Amazon in less than 4 clicks, which is almost dangerous. But if I want to, not me, but if I watch Terry discharge a patient, it's 50 clicks. Some physicians are engaging in 100 clicks to discharge a patient. How come I can order something to Amazon in 4 clicks, but 100 clicks to get a patient out the door? Seems a little bit funny. So I'm going to touch on some of those things. And when I was designing this talk, what I wanted to do is tell a story about our portfolio and things that we've been working on. And it's, I give this kind of silly example of clicks and Amazon and so forth, but it's certainly that clinician frustration is a big piece of this, but really what we're dealing with here are patients' lives and all of the safety issues that come up when we try and interact with our EHR. And you can see some of these headlines now that are slowly starting to hit the popular press. And I wish there was this bigger push in the popular press to cover more of this. And you can see some of the headlines here. Turn off the computer and listen to the patient was a big feature in the Wall Street Journal. The safety of electronic health records and so forth. And so I want to start getting into some of these issues, part of it from the clinician side, but also from the policy side. So you can see what's actually happening behind the scenes for those folks that aren't policy geeks like myself. So we've been actively doing a lot of research work in health information technology, for the last Terry's been involved for the last 10 years. For me, I used to do a lot of work in defense and transitioned to healthcare about 5 years ago and very quickly started doing work in electronic health records. And we have a couple large grants in this area and several contracts. And we've really, I think, tried hard to not just do studies that are important to do, that sit in the publications and get dusty on shelves, but try and push policy a little bit and try and influence the decision makers. And I'm hoping to show you some of that and hopefully try and get some of your engagement there as well. So our basic approach is we kind of have one thrust area where we spend a lot of time studying the impact of health information technology on clinicians. So how does it change their work processes? What kind of new mechanisms do we need in place to make these systems safer? And how can we stop the conversation about safe health IT and start talking about how health IT is actually going to make patient care more effective, efficient, and safe? And the second big thread for us is really around understanding the multiple stakeholders involved in health information technology. I think too often we get very vendor-centric. That is, we point to our particular EHR vendor, Epic, Cerner, whoever it is, and say, wow, this is their problem. And certainly there are things, and much of my talk is going to focus on some of the things that they do wrong, but a lot of this involves all of us being engaged and helping those vendors get to the right place. And I want to touch on some of those points. And the final point is, what really are the policies and how are vendors adhering to those policies and what can we do to those policies? So that's kind of the different areas that I'm going to talk about. So I have to start with this kind of formal definition of usability and user-centered design. If you kind of engage in Usability 101 or pick up any definition of what usability is, typically this is what you'll find. It's the extent to which any product, process, technology can be used by specified users, in our case generally clinicians, to achieve specified goals. And really we're looking at three things: effectiveness, efficiency, and satisfaction. So can people reach their goal in an effective way, efficient, satisfactory way, and is it safe? And oftentimes we hear from folks, well, usability is not measurable, and I want to kind of crush that one right away. It's absolutely measurable, and there's lots of different ways to measure it. Not only is it measurable, it's critical that we measure it, particularly in environments like healthcare, where there are very serious consequences to poor usability. And one of the main ways to kind of improve your chances of a highly usable product is to engage in what's called a user-centered design process. And the basics behind user-centered design is you want to put the needs of your end users at the forefront of design and development. So from the get-go, you kind of start in the upper part of this box here, where you're really trying to understand the context of use and how people do their work. You use that to develop some initial prototypes, and you're continually bringing your product back in front of those users to get their insights on how this technology should be designed and developed. And eventually then you settle on a product that should meet their needs. So it's continually testing and putting in front of users. Now, that's kind of the formal definition. This is probably one of my favorite slides. This is a photograph taken by Dr. Bob Wears down at the University of Florida, and you can see this really fancy electronic whiteboard on the right-hand side with virtually nobody looking at it except for the gentleman on the phone, and everybody's looking at the dry erase board on the left-hand side. That's the really cheap, piece of equipment here, right? But it's incredibly usable. And what you see here is that it breaks all of the stereotypes that we typically see. You'll see old folks and young folks looking at the whiteboard. So this is not an issue of age, which we often hear, like, oh, the more senior people just don't want to engage in technology. That's just not true. This breaks the gender issues. There's no gender gap here, right? This is about, is the technology usable or not? And the way that we like to talk about usability is there's really kind of two components to it. There's basic interface design, and there's cognitive task support. And the user interface design element of usability really has been solved for the last 50 years. And it's very frustrating for me as a human factors practitioner to come in and see that we still see issues of font color and font size and number of clicks. Those problems have all been solved. Pick up a textbook and you'll see the answer. So these are really context-independent issues, right? Making sure that it's not a yellow font color on a white background. We know not to do that, yet we still see issues there, which is just amazing to me. But the user interface design elements are important, but they're solved. They're context-independent, font sizes, icons, color and contrast, overall layout. Where we're really failing when it comes to health IT and electronic health records is in the second group over here on the right-hand side of the screen, the cognitive task support. And this is the stuff that's actually really, really hard to do well. It takes tremendous expertise. It takes tremendous investment. It's context-dependent. You have to get into the environment and understand how people do their work. If we take how technology is developed and the user needs in healthcare, it's going to be completely different from those needs in aviation because there's complete context specificity here. If you look at those user interface design elements, that's generally not the case. Those are general principles that can be applied across industries. So when it comes to cognitive task support, we want to make sure we're supporting the memory of our clinicians. Or do we have the right information on the screen when they need to place a medication order? We want to anticipate the kinds of errors people are going to make. And Terry gave I think the really concrete example of the projector. And really visualization in the sense that we know the way we represent information and present information to our clinicians is going to impact their reasoning and decision making, and we want to do that effectively. And to really build a system that achieves our ambitions around cognitive task support, we have to get into the clinical environment and we have to understand our clinician needs. So that's, I think, the easier to digest and more concrete description of usability. Two elements, user interface design and cognitive task support. Now I'm going to transition a little bit and talk about three different kind of pieces of work that start building from understanding frontline clinician impact, the impact of EHR technology on our frontline clinicians, into what are vendors doing when it comes to usability. So what are the Epics and the Cerners and the small vendors of the world doing when it comes to building usable products or unusable products, and what does policy look like around that? So I want to start with the frontline impact piece. So a few years ago, we looked at emergency physicians and their transition from a homegrown electronic health record system to a commercially available electronic health record system, where the biggest difference really was the introduction of CPOE. And we did this observational study with 14 EM physicians where we went into the environment and tracked all of the tasks that they did very simply on paper. We had researchers go in and observe them for 2 or 3 hour blocks and say, are they working on the computer? Are they working on paper? Are they seeing a patient? We did that on a minute-by-minute basis. And we did it in 3 different phases. We first did it pre-implementation, so this was on their current system prior to the new CPOE, which they did not have before. We then did it within the first 3 weeks of CPOE and the new commercially available EHR going live. And then we did it post-implementation 3 months later. And we wanted to see how this process, how their work processes changed over time. And we were the first thing we did is we looked at task allocation time. And when we looked at these data, we're actually a little bit disappointed because it followed what you might suspect. So if you look on the far left here, we're looking at computer time, and the darkest gray bars are the pre-implementation, the light gray bars is that go-live phase, and then the third middle gray bar is the post-implementation. And on the x-axis, you have the various tasks that they're working on. On the y-axis, you have the percentage of time that each physician worked on this in an aggregate. And what you see is when we first, in the pre-implementation, they spend roughly 25 to 30% of their time on the computer. When you go live, you would naturally expect that people are going to spend more time on the computer. They have to get used to the system. That's what we found. And then we looked at post-implementation. We're like, wow, computer time actually went back down pretty much to where it was before. So maybe the EHR actually doesn't have that big of an impact on folks. You look at verbal communication, it goes up, then back down to where it was. Unfortunately, we see patient time in the patient room go down during go live, but look, it comes right back up. And time on paper is a little bit funny because in this particular ED, we're still partially on paper. You might look at these data and say, Raj, you just wasted a lot of time and money. You just spent all this time doing this study and there's no difference. Go publish it in that journal of no differences where no one cares. And then we said, but wait a minute, that just doesn't make sense because every one of my clinician colleagues that I talk to, it doesn't matter what the context is, they're always complaining about the EHR. It could be Thanksgiving and we're having a great time watching football and they're still complaining about the EHR. I don't get it. What is happening? So we looked at the data in a different way and we said, well, how many tasks do they complete in any given minute and how many times are they switching tasks? And we're like, wow, this is pretty incredible. So we looked at the different, the number of tasks and amount of task switching, number of tasks they take on in any given minute. And what we found is that pre-implementation, the light gray bars is generally when they're doing 1 task, the middle gray, 2 tasks, 3 tasks, 4 tasks. They're typically doing 1 or 2 tasks per minute when in pre-implementation. When they go live, that starts to increase. Post-implementation, we see a dramatic increase, a significant increase in their task load, the amount of tasks that they have to complete in any given minute. And what we're seeing is that the way the health IT systems are designed is that they're continually going back and forth between asking a particular nurse a question, going back to the HR, looking down at paper, going back to the HR, because all the information is not in the place that they need it to be. So part of what's likely driving their stress is the fact that they have to continually sort of battle against the EHR to get their tasks done. We're seeing this constant task switching or task load increase. And what we know from the cognitive literature is that as we increase task load, there's an increased likelihood of error, and we see incredible frustration and burnout. So I was a little bit happy that we at least found that there was this difference and not just the task allocation time. And it's worth noting that these kind of data, if you just look at task allocation time, is often what we hear from vendors. They'll often show you data and say, no problem, there's going to be a little hiccup in the first couple of weeks, but everything's going to return back to normal. Well, in reality, it doesn't really return back to normal. And our hunch as to why we're seeing the time allocation return back to normal is that physicians are compensating. They're compensating to get this back down, to spend more time with the patient, but in reality, that compensation is in the task load. So some of that summary is right here. It's essentially the cognitive cost of using the electronic health record is this increase in task switching. So that was our big push to say, well, okay, we have some data that clearly shows there's a major impact of electronic health record. Now let's start thinking about what are really the policies that drive EHR vendors when they design and develop their systems. So there's this organization called the Office of National Coordinator, which some folks may be familiar with. It's part of the Health and Human Services, Department of Health and Human Services, and is really charged with overseeing the rollout of health information technology. And to the ONC's credit, they could foresee that usability may very well be a significant challenge of these systems. And so early on in their certification requirements, they put in key criteria that vendors must adhere to. So in order for healthcare providers to receive their incentive payments for using health IT, they have to use a certified health IT product. And to be a certified health IT product, for a vendor to build a certified health IT product, they must adhere to a whole host of certification requirements, and then those certification requirements get tested. Around usability, there are two key components that vendors must achieve. The first is they have to attest to using a user-centered design process. So that early slide that I had with that circle of the process, they have to raise their hand, really provide a written statement and say, yes, we used a user-centered design process, and they're supposed to report the process that they used. And the second thing that they have to do is they have to run what's called a summative usability test. So once they've designed their product and they're sort of done with it, they have to run this final usability test, and they have to test a subset of functions and report those results. And for all the vendors that pass, their results are made publicly available. So anybody can go onto the ONC's site and pull the reports for every vendor, every product, and see how they've tested it. Okay, so those are basically the requirements. So early on in 2013, we started working with the ONC. At that time, Jacob Ryder was our primary driver there, and was very insightful and said, you know, I really want to know how, I want to do a usability study on vendors. I want to know how vendors are engaging in a user-centered design process and what are their barriers. And so what we did is we traveled to 11, 12, 13 different EHR vendors, and we spent somewhere between 3 and 8 hours with them, and started talking to them about what their user-centered design and usability processes are, what are some of the challenges that they face, and what could be done to potentially overcome those. So this was more of an informal kind of study, very qualitative, and we went in this very non-threatening way, sort of saying, we're researchers, we're here to understand, and we'll likely publish our results, but it'll be totally blinded. So that was the project we engaged in. Here's a sampling of the vendors that we went to. So it was, I think here we have 11 different vendors, and we tried to get a pretty diverse range. So you can see we have a couple of the really big ones, the $1 billion plus revenue at the top, all the way to a couple very small vendors, right, $300,000 or so. So we can see how their processes are related to this. And interestingly, what you'll see, despite those requirements I just told you about related to usability and certification, is you can see their user experience or usability team size. Some don't have any. Right? So they need to engage in these usability processes, but they don't actually, this is old data now, 2013, but didn't actually have usability folks to do so. And when we started doing our analysis of all of the notes that we took from the research team that we sent out, and I went on each visit and then was always accompanied by a physician with me that also understands human factors and usability. So there's always two of us, at least two of us, engaged in this process. And what we found is we could break each vendor down into basically 3 different categories. First category were those that really have no clue what user-centered design and usability is. They're very much focused on getting customer feedback, which is not really usability, that's just good business practice, right? You want to understand what your end users are complaining about so you can improve your product. They didn't really have a formalized method in place to actually design and develop effective products. The second group was a basic, what we call the basic user-centered design group. So they know that user-centered design is important. They typically have buy-in from their high-end leadership, but they don't have their processes fully formalized and fully integrated across their suite of products. They're still kind of trying to work out a few glitches, and I'll talk about some of the more specific challenges in a minute. And the third category is this well-developed user-centered design group. They have rigorous user-centered design processes in place. They've really figured out a great infrastructure to get their testing done. They can get participants easily. They're doing a lot of remote testing. They figured out all the efficiencies here. And roughly 1/3 of the vendors fit in each one of these categories. We're only talking about 11 vendors. We don't have a lot of data, but roughly 1/3 into each one. And from the limited data that we have, there was no clear correlation between size of the vendor and the category that they fall into. Now, I think it's worth talking about the specific challenges from each group, because this, I think, starts to push the conversation around this is not just a vendor problem. As all of us engaged in this health IT journey, we need to look at ourselves as stakeholders and need to think about what we can do to potentially contribute. So for the No True User-Centered Design group, that's a tough group to deal with. In terms of their challenges, it's really a matter of convincing their leadership of those organizations to realize the importance of user-centered design and usability. It's going to take pushing these products to being in a more competitive market so that there's costs to not having a great usable product, which right now there's really not. That's a tough group to influence. The group where I think we can have a lot of influence is the basic user-centered design group. This particular group is really struggling with things like participant access. So they actually have a really hard time getting clinicians to participate in their usability studies. Now, that's a key part for us, right? Us as end users need to be working with our vendors to ensure that they have folks to actually test. For the well-developed group, they really understand how to do this quite well. One of the things that they certainly were vocal about is safety data. They actually don't have a lot of access to safety data. So if there are safety hazards with their particular product, they don't have a good way to analyze those data and even get access to those data. And the second thing is that this group spends a tremendous amount of resources to understand workflow and work processes in several of the different subspecialties, but that is constrained and confined to just that vendor. So now we have vendors that are expending tremendous resources to study the same subspecialty, when in reality we can create a mechanism to share all that information. So I think there's some good learnings there. So this is what we found with the vendor visit work. Now, that sort of pushed us to say, well, so we have some insight here that there's a third, maybe 2/3 that don't quite have the usability processes that they need to. And we just talked about the O&C requirements for building certified technology. So are vendors actually adhering to policy? So we started looking at those publicly available documents, and we focused specifically on CPOE. So early on, I had said that there's a subset of capabilities that must be tested by the electronic health record vendors. One of those is computerized provider order entry. So we looked specifically at the public reports put out by vendors around CPOE, and we did two simple things. We said, do they actually report a UCD process as is required to build a certified product? And let's take a look at the participants and the demographics of the participants that they run in that summative final test. Anyone want to venture guesses as to what we found? We were shocked ourselves. We analyzed the data 2 or 3 or 4 times to make sure we're actually right here. And what we found is that a full third actually don't report a user-centered design process. Interesting, because that matches our 1/3 of the vendors that we visited didn't actually have a user-centered design process. And I'm probably going to say this multiple times, but keep in mind that all of these products were stamped by the federal government saying that they adhered to these usability processes. But they didn't actually adhere to these usability processes. And these products are now in our hands and being used to treat our patients. So a full third did not report a user-centered design process, although they're required to. And then you can see the breakdown of the other processes here. And we don't have any great insight on which of the other processes or whether one is more effective or not. The fact that they're engaging in a process here is good to see. And the second thing, and perhaps even more shocking, is we looked at the participants that they actually used in their summative testing. So remember I said that we looked at the CPOE component of testing. So who are the primary users of CPOE functions? Clinicians, generally physicians and nurses. And what we looked at are two things. Number one, we looked at the number of participants they used in their study. And the National Institute for Standards suggests 15 participants be used in their testing. So we looked at how many participants did they use. And then of those participants, we looked at how many actually had a clinical background of any sort versus ones that don't have a clinical background. So the dark gray is the clinical background, the light gray is no clinical background. And shockingly, you're going to see several vendors that, number one, do not run enough participants in their study, so they may not be able to actually discover many of the issues that are actually in their system. And number two, many of these vendors, and some, have no clinicians whatsoever engaged in their process, in their testing. So it'd be like running me, who has no clinical background, on a CPOE function and asking me whether it's safe in the way this is designed to prescribe medications. It's just ridiculous, right? So we were very shocked to see this, and I warned you and said I was going to say it multiple times. I'm going to say it again. These products were all certified as passing these requirements and stamped as being usability safe and deployed into our healthcare systems to treat our patients. So we were very, very shocked. So one of the things that we've started to do now is try and take this information that we have about the usability of these products and make it more transparent. So we're in an interesting position here where if you don't like the usability of your cell phone, which maybe costs a couple $100, you throw it away, you get rid of it, and you get a new one. If you go purchase a new DVD player for people that still use DVD players, you don't like it, you go get a new one. But when we talk about electronic health records, that's just not possible. Right? We're talking about systems that potentially cost hundreds of millions of dollars. There's potentially some data blocking issues. We have to transfer all of our patient data. And we are incentivized to purchase and use these systems. So we really don't have a perfectly competitive market here. To try and move this to a more competitive market, we firmly believe that we need greater transparency around not just the usability processes of each of the vendors, but we want to be able to, at some point, comparatively test the usability of electronic health records, which there's clauses that actually prevent doing that. So our first pass at doing this is we partnered with the American Medical Association, and we looked through several of those vendor reports that I talked about that are on the government website, and we broke it down into 3 categories. The first is, do they report a process, and what is it? The second is, what methods do they use to do their testing? Are they actually using the right metrics here? And the third is, do they talk about improvements to their system, which is the key purpose, one key purpose of doing this testing. And we created a simple 15-point grading scheme around this and made it all publicly available. And we did it, I think, for about 20 vendors. And so you can go to healthITusability.org and you can see the 20 vendors that we looked at, and you can see their scores, and you can see where they fall on this. And the push really here was to get the conversation started around transparency. And I think we've done that. And my hope is now that eventually we can move to a true comparative analysis, usability testing of each of these systems, and get that out to folks before people are making decisions on their next iteration of EHR if we get to that point. And what we found is, and this again is in common with many of the data I just talked about, the use cases that vendors developed lack rigor. So they do very simple things like go up and click to order Tylenol, which is really not testing the safety and capabilities of your CPOE mechanism. We need much more in terms of complexity to test those well. The metrics are inconsistent, and actually I took out my favorite piece here, which is one of the metrics is testing the effectiveness of the system, which is basically, if you bring in 10 participants, what is their success rate at completing a task? And it's pretty simple. If you take the number of times someone tries it as the denominator, the number of successes, and calculate a percentage. And there's one vendor that actually just calculated partial task success. So instead of looking at a binary, yes, they completed it, or no, they did not, they said, how many steps did they get along the right path? So if there's 6 steps required to complete a particular task, and they got 3 of those, that would be 50% success. From my limited experience in healthcare, although I've gotten lots of medications for myself and kids, at no time do I go to the pharmacy and do they say, well, we have 50% of your order here, and we're waiting for the physician to get the other 50%. It just makes no sense. And we'll stay away from naming specific vendors, but I'll say it's an epic failure in the way that you calculate success rates there. So we were shocked to see some of those particular elements. So what now? This is sort of the last slide where I kind of wrap up. One of the key pieces, I think, is that we need to really find ways to incentivize greater partnerships between providers and stakeholders and our vendors. So much of this talk is vendor-centric, but there's lots that we can be doing as a community to help push this along. And one of those things also is being very vocal about how unsafe these systems are. In healthcare, we're often, as I mentioned, I'm coming from a defense background. When I first came into healthcare and I shadowed Terry within my first week, I was shocked to see the way things are done in healthcare, and that everybody sort of just accepts it. They sort of say, okay, you've handed me this bad system, I'm going to use it. It's a positive quality because we're adaptive. It's negative in that we're not actually vocal enough to push to make the changes that we need to make. The second piece is around transparency. I talked about this a little bit. I think a really big element here too is we need to find the right ways to share our safety data that we have through our healthcare systems with those vendors. And we actually have a pretty large grant now where we're mining a large database of these safety events, finding commonalities across vendors and trying to disseminate those. And the third piece is really pushing to optimize current regulation. And there's lots of initiatives through the Senate Health, Education, Labor, Pension Committee to try and do some of that. And I think that's going to be a big piece to the long-term play to improving these systems. So I'm going to stop there and thank you all for your time and attention, and we're happy to take questions.